The following presentation is copyrighted by Medscape Education. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape Education. The following podcast is supported by an independent educational grant from GlaxoSmithKline.
Hello, I'm Dr. Jay Wish, Professor of Clinical Medicine at the Indiana University School of Medicine in Indianapolis, Indiana. Welcome to this program titled, Are Gaps in Anemia and CKD Equal Across the Board? Part of the Updates and Advances in Anemia of Chronic Kidney Disease series. Joining me today is Dr. Ajay Singh, who's Senior Associate Dean for Postgraduate Medical Education and Director of the Master in Medical Science and Clinical Investigation Program at Harvard Medical School. He's also a physician in the renal division at the Brigham and Women's Hospital Dana-Farber Cancer Institute in Boston, Massachusetts. Welcome, Ajay.
Thank you.
By means of introduction, anemia is a common complication of chronic kidney disease. It's estimated that the prevalence of anemia in patients with CKD increases as the disease progresses, and about 50% of all patients with stage 5 CKD, the most advanced stage prior to requiring dialysis, have associated anemia. This podcast is episode 4 of a 6-part podcast series on understanding and managing anemia in patients with CKD. In this episode, we'll focus on health inequities related to CKD. I will ask Dr. Singh questions if certain patient populations are being underserved in their management of anemia with CKD. We'll also try to dive into what and why these disparities exist. The first question is a general one. Are there disparities in the prevalence of CKD among racial, ethnic, and socioeconomic groups?
Well, Jay, absolutely. This has been well appreciated for a number of years. Black or African Americans are more than 3 times as likely, and Hispanics or Latinos 1.3 times more likely to have kidney failure compared to white Americans. As well, compared to whites, American Indians are about 1.2 times more likely to be diagnosed with kidney failure. Among African Americans and Latinos, the commonest factors that seem to drive this are genetic factors because of the ApoL1 variant, high-risk variants, higher rates of blood pressure, diabetes, obesity, and among American Indians, diabetes is the leading cause of kidney failure. Socioeconomic factors are also very important. In fact, a number of studies, including the REGARD study, which was conducted in Southeast eastern states of the United States, showed that economic factors among both Blacks and white patients was an important risk factor for CKD.
So let's get back to teasing out some of these disparities as being to genetic or environmental factors or both. What's the story there?
Well, the explanations for the higher rates of kidney disease in African Americans can be generally thought about in 3 broad categories. First, genetic variants in the apolipoprotein L1, ApoL1 gene cause high rates of kidney disease in African Americans. These variants are found only in individuals with recent African ancestry, confer an enhanced innate immunity against African trypanosomes, and so they provide a survival benefit in Africa, but in the United States, they actually increase the likelihood of African Americans having kidney disease. Beyond that, the presence of these variants increases the rate of progression of CKD among African Americans who have this variant. Second, there's a higher rate of diseases such as diabetes and hypertension among African Americans and other minorities that increases the risk of kidney disease. And third, as we've discussed, poorer access to insurance and medical care that then leads to delayed diagnosis and delayed care, including reduced access to some of the exciting new medications, actually might increase the rate of progression of kidney disease.
So let's talk a little bit more about these barriers to healthcare access. How do you think they specifically accelerate the progression of CKD in these underserved populations?
There is, of course, in America, access to care, but it's unfortunately complex. This access of care, fortunately, has improved with all the work that came along with respect to Obamacare. People have have health insurance more than they did in the past. This has benefited people who are in lower socioeconomic classes. But in addition to that, there are important contributors to disparities in quality of care and clinical outcomes that I think are important to consider. And this reflects some of the work of Nicholas and co-workers and Cruz and colleagues and others. The three big factors that seem to be impactful are social-based health disparities that encompass institutional-based discrimination and biases and racial segregation, as well as economic and educational injustice. Healthcare disparities, I refer to this in terms of access and operation of health systems. And then last but not least, just the economics of being poor reduces the ability to make co-payments for medications. Transportation becomes a factor in reducing access to care. So there are a number of factors that work in synergy to compound the disparities and accelerate the progression of kidney disease and the development of complications.
So let's shift from CKD in general to anemia in particular, one of the common complications of CKD, to what are the barriers in healthcare access? How do they compound these disparities that affect the anemia treatment?
Yeah, to set the stage on this, let me just share with you some data. My colleagues and I did a study looking at the NHANES data set. This is a representative data set that's very commonly used to examine questions related to the population as a whole in the United States. And our goal was to determine what the rate of anemia was, and we defined it in different ways. We used the WHO criteria of hemoglobin of less than 12 for women and less than 13 for men. We used more conventional sort of what I call CKD criteria or kidney criteria for anemia. And regardless of whatever criteria you use, anemia is much worse among non-Hispanic Blacks compared to Latinos or white patients. And this difference has been present for the last 20 years, from 1999 all the way through to the present era. But what's also interesting and unfortunate in this data is that this anemia has gotten worse. The gap in anemia between African Americans and Latinos and whites has actually gotten worse in the population. And so then it begs the question, what explains that? And part of it is that that socioeconomic factors, poverty has been a really important factor. Related to poverty, of course, is diet. Patients who are poor don't have a diet that's rich in iron. They're much more likely to be iron deficient. Poverty also means that access to transportation and access to hospital care becomes less. So going to EPO clinics and receiving treatment, going to get your appointments becomes less easy. Educational inequalities are also quite important. So a number of barriers exist that work together to unfortunately explain, I think, a significant portion of this gap between anemia in African Americans versus anemia in Latinos or white Americans.
Thanks, Ajay. That's an excellent answer. What are the clinical and economic consequences of some of these disparities in the access to the treatment of CKD as well as CKD-associated anemia?
Right. So a number of studies have demonstrated that lower hemoglobin levels, particularly very low hemoglobin levels in patients with CKD, impact health-related quality of life. Data that coming from observational studies, but also from placebo-controlled studies where patients treated on placebo compared to those where anemia is corrected with an ESA demonstrate that patients who are anemic have lower health-related quality of life. It's not been demonstrated consistently in every study, but I think most nephrologists buy the fact that severe anemia impacts quality of life. But it also causes reduced energy levels more specifically, and that then influences work productivity. And this is really important for our population. Separately, colleague of yours and mine, Bruce Spinovitz, published an interesting review where he looked at the relationship between CKD anemia, health-related quality of life, and health resource utilization. And specifically with respect to costs, he presented data that shows that there is a higher health related resource utilization in patients with anemia, and that costs are higher among patients who are anemic than in patients who are not anemic. And I think that these two factors are really important. They're important to our patients, and they're important to our patients and providers, because ultimately providers then have to deal with all the complications that come downstream of sustained long-term anemia among patients.
So just to kind of wrap things up, we'd like to look forward to a more hopeful state of affairs where some of these disparities are better addressed. Have there been any recent developments, including system changes or even new products to address some of these disparities?
Yeah, so there have been a number of initiatives, and I'd like to say that the Medicare, CMS, and others have been really upfront in advocating for measures that might look at not only quality of care among CKD patients, but more specifically, quality of anemia care among CKD patients. A new measure in dialysis patients that's emerged is the standardized transfusion rate. And this measure looks at what the rate of transfusion is among dialysis patients in the United States, and it standardizes, of course, this rate so that you can compare different regions of the United States. Other changes, as we know, because of changes in reimbursement policy in the United States, have emerged such that now we have value-based care and companies that focus on value-based care. These companies are now taking on patients at risk, where they are responsible for all of the risk in the population and all the costs. There's an incentive if they keep the costs down and keep quality up or high. And because these companies recognize that it doesn't really matter whether you have a Latino or African American or white patient, if they're anemic, that the anemia, as well as other complications of CKD, will drive up hospitalizations and other costs. They become much more focused on trying to develop management algorithms that manage this disease better. And part of these algorithms include addressing health literacy, educating patients better, getting them more access to care, greater attempts to identify and diagnose disease at an earlier stage, and then mechanisms to treat and monitor disease, including anemia. So I think changes are there, and I hope that we will see these changes having a beneficial effect. But the good news is that things are changing.
Yeah, I think you didn't mention, but many of these things that you did discuss fall under the Advancing American Kidney Health Initiative, which has a better focus on upstream care of the CKD and its complications, rather than waiting till the patient gets on dialysis or in a more advanced stage.
Absolutely right. And thank you for bringing that up. You're absolutely right.
Well, I'd like to thank Dr. Singh for an excellent discussion. I really appreciate your sharing your wealth of knowledge and expertise. And I'd also like to thank our audience for participating in this activity. Please join us for the remaining podcasts in this series, Updates and Advances in Anemia of Chronic Kidney Disease. We hope you enjoy the rest of your day. Please continue on to answer the questions that follow and complete the evaluation. We really appreciate your feedback as it helps us develop future educational programs.